The kanski lecture series with the chapter 11 glaucoma part 10, and in this part we are going to discuss about the steroid induced glaucoma. Around basically some patients are steroid responder. So what is the steroid responder? The patient is using the topical steroids, and after the use of sometimes after the topical steroids he developed glaucoma, so that is known as steroid induced glaucoma. Around 1 in 3 individuals develop some degree of elevation of IOP in response to a course of potent topical steroid, dividing the population into the steroid responder and non-responders. Responders are more likely than non-responders to develop POG, and a majority of the patients with POGs are responders. So basically, there is most of the patient who have a tendency to develop into primary open-angle glaucoma are responders. Steroid induced glaucoma is a form of secondary glaucoma which is typically associated with the use of the topical, periauricular, intraocular, or steroid therapy, although it can occur with any type of the corticosteroid administration. So basically, most of the time it occurs with the topical steroid, but it can occur in any kinds of the corticosteroid administration. The rise in IOP is a consequence of increased resistance to the outflow of the aqueous, secondary to the altered function of the extracellular matrix or endothelial cells of the trabecular meshwork. So it is just telling us the pathogenesis, that basically there is a resistance of the outflow because there is an altered extracellular matrix function, or there is a trabecular meshwork endothelial cells that have been altered. The IOP elevation is dependent on the steroid type, potency, dose, duration, and route of administration, and usually occur 2 to 4 weeks after the commencement of treatment. The rise in IOP after intravitreal triamcinolone typically lasts 2 to 4 months, and after dexamethasone intravitreal implant Ozurdex up to 6 months. The clinical picture resembles that of a chronic open-angle glaucoma with normal appearing anterior chamber angle and absence of symptoms. So basically, it usually occur with intravitreal triamcinolone, and that is usually last for 2 to 4 months. Or it can also occur after the dexamethasone intravitreal implant, which is after up to 6 months. The clinical picture resembles that of a chronic open-angle glaucoma, and with a normal appearing anterior chamber angle and absence of symptoms. Much less often than the condition may result in acute presentation with pain and a significant IOP rise. So patient just present like a poke, but whenever you take a history of a patient with poke, he has some use of a steroid, so you then diagnose it as a steroid induced glaucoma. Risk factors: established glaucoma or ocular hypertension, family history of glaucoma, high myopia, young age, especially childhood, connective tissue disease, especially rheumatoid arthritis. Very important, rheumatoid arthritis is a risk factor for developing glaucoma. Treatment: discontinuation of this topical steroid is usually all that is required to reduce the IOP back to normal. In the acute form, this occurs within days, and in the chronic form, within 1 to 4 weeks. So within days, it returns to normal, and in chronic form, it takes 1 to 4 weeks to IOP to become normal. A less potent steroid drop can be prescribed, for example, fluoromethanol 0.1%, remixolone 1%, loteprednol, itaponate. So you can, or if there is a necessary to use the steroid, then you can always switch to a low potent steroid drops like FML, remixolone, loteprednol. In 3% of the patient, elevated IOP may persist despite stopping all the steroid. The duration of steroid therapy influences the reversibility of the IOP elevation. This is usually seen in patients with a family history of glaucoma. Persistent IOP elevation should be managed with medication or glaucoma surgery. Steroid-induced raised IOP is unlikely to occur in the presence of an established plan. In any patient with raised IOP who is using topical steroid, simply discontinuing the steroid will often result in the rapid reduction of IOP, thus identifying the patient as a steroid responder. There is a lens-related glaucoma. There can be phacolytic glaucoma and phacomorphic glaucoma. So what is a phacolytic glaucoma? Phacolytic glaucoma is a secondary open-angle glaucoma. So it is an open-angle secondary glaucoma, occurring in association with the hypermature cataract. The trabecular obstruction is caused by the high molecular weight lens protein that is leaks through the intact capsule into the aqueous humor, leading to the trabecular obstruction. So this is a phacolytic. Phacolytic mean that the mature lens capsule is releasing the proteins which are causing the reaction in the AC and obstructing the trabecular meshwork. So that is how you get the secondary open angle glaucoma. Macrophage containing lens protein may also contribute. Phacolytic glaucoma should not be confused with phacogenic, previously known as phacoanaphylactic uveitis, an autoimmune glomerulomatous reaction to exposed lens protein occur with the compromised lens capsule. So there are three terms: phacolytic and phacomorphic and anaphylactic. So phacolytic is basically the hypermature cataract is releasing the lens protein. Phacomorphic glaucoma is that a hypermature cataract is obstructing the pupil and will causing the not the flow of aqueous from the posterior to the anterior chamber. Whereas phacoanaphylactic is that a capsule has been compromised either from the surgery or from the trauma, and there is a granulomatous reaction after that. Diagnosis. Presentation is with pain. Vision is poor due to cataract. Slit lamp biomicroscopy show corneal edema, hypermature cataract, and a deep anterior chamber. So in this case, you can see that there is an open angle, there will be the AC will be deep, there will be the hypermature cataract, and there will be the corneal edema. There may be large floating white particles in AC consisting of a lens protein and protein containing macrophage. And there can be the aqueous flare and the white particles in the AC, which may impart a milky appearance to the aqueous if very dense and can form a pseudo-hypopyon. Gonioscopy, if a reasonable view can be obtained, shows an open angle with the lens-derived material and inflammatory cells that are more substantial inferiorly. Treatment. After IOP is controlled medically, proteinaceous material is washed out from the anterior chamber and cataract is removed. Care should be taken not to rupture the zonule, which is likely to be more fragile than usual. So basically the treatment is to just remove the cataract. So this is a phacolytic glaucoma. A is showing lens protein containing macrophage in the angle. B is showing hypermature cataract, lens protein containing macrophage floating in the aqueous. C is showing the dense milky aqueous with pseudo-hypopyon. D is showing residual particle in the anterior chamber following incomplete irrigation after complicated surgery. Phacomorphic glaucoma. Phacomorphic glaucoma is an acute secondary angle closure glaucoma precipitated by the intumescent cataractous lens. Equatorial age-related growth of the lens slackens the suspensory ligament and allows the lens to move anteriorly. Associated anterior-posterior growth leads to increased iridolenticular contact and potentiate pupillary block and iris bombe. So basically in a phacomorphic glaucoma, the cataract becomes swollen, and due to the swollen lens, the pupil become obstructed. So when the pupil become obstructed, the aqueous humor from the posterior chamber will not flow to the anterior chamber, so it will cause the increase in the intraocular pressure, and there will be the pressure build up in the posterior chamber, and there can be the iris bowing as well, causing the iris bombe formation. Diagnosis. Presentation is similar to the primary angle closure glaucoma with a shallow AC and mid-dilated pupil. A dense white cataract is evident. The fellow eye phacomorphic glaucoma is more likely in eyes with a shorter axial length and a shallower AC, but the fellow eye may demonstrate a deep AC and an open angle. Anterior segmentosity or ultrasonography biomicroscopy may be useful. Treatment. Medical treatment is initially similar to that of a primary angle closure glaucoma. Myotics are omitted as they tend to increase the iris lens opposition and shift the lens anteriorly. Dilatation is sometimes helpful, but they should be implemented with caution. So myotics are not recommended in this case. Systemic hyperosmotic agents such as may be required more commonly than in primary angle closure glaucoma. Laser iridotomy may be worthwhile but is not often possible due to corneal edema or lens cornea proximity or ineffective. A similar procedure should be considered for the fellow eye. Laser iridoplasty may be a useful temporary measure. Cataract extraction constitutes the definitive treatment, ideally once the IOP has been normalized and the eye is quiet. The surgery can be difficult and carries a high risk of complication. So the definitive treatment is to remove the cataract in a case of the phacomorphic glaucoma. You just control the IOP medically and you just remove the cataract. Pupillary block from the disruption of the lens position. So blunt ocular trauma, even if relatively trivial, may result in a lens dislocation in eyes with a weak zonule, as in pseudoexfoliation and homocystinuria. Congenitally small lens, microspherophakia, wheel Marchesani syndrome. So if the lens is getting dislocated and it is causing the pupil to be obstructed and causing the not the flowing of the aqueous humor from the posterior to the anterior chamber, it means that it is a pupillary block from the disruption of lens position. So during blunt trauma you can also get the dislocation of IOL or subluxation. So in a wheel Marchesani syndrome, it can also cause, there is a small lens that is causing the pupillary block. Dislocation may be into AC, the zonule may be stretched, or only the part of the attachment may be disrupted, so that intact part act as a hinge and the lens may remain fully or partially in the posterior chamber. Vitreous herniation may be contributory. A lens fully or partially dislocated into the anterior chamber will usually be evident. Acute pupillary block will cause a sudden severe elevation of IOP with associated visual impairment. Imaging such as ultrasound biomicroscopy may be diagnostic. The IOP is initially reduced with the osmotic agent which reduces vitreous volume. Treatment should be urgent as prolonged lenticulo or corneal contact, particularly in the presence of high IOP, may cause a permanent endothelium damage. So basically the treatment depends upon the location of the lens being dislocated. If the lens is contacting the cornea, then the lens should be removed as soon as possible because it can cause the permanent endothelium damage. Initial treatment, the patient should adopt a supine posture with the pupil dilated to attempt to reposition the lens in the posterior chamber, following which a myotic can be used with caution. Bilateral laser iridotomy may provide extended control in some cases, but lens extraction may be necessary. Definitive treatment consists of the surgical lens extraction and anterior chamber IOL, iris or scleral fixated IOL will be necessary. So in case of the traumatic or whenever there is a zonular weakness and there is a lens dislocation, definitive treatment is that you just remove the lens and you can place either the anterior chamber IOL or scleral fixated IOL. So this is showing the intumescent cataract, shallow anterior chamber, dilated pupil and corneal edema in phacomorphic glaucoma. 11.50 is showing the traumatic dislocation into the anterior chamber of a normal size lens. Next is a traumatic glaucoma. Traumatic glaucoma be due to hyphema or angle recession glaucoma. So hyphema is basically after the trauma. There are the blood formation in the anterior chamber due to some damage in the vessels, and it can cause obstruction in the so the RBCs that are being produced cause the obstruction of the trabecular connection and can produce glaucoma. Hyphema introduction in a patient with a small traumatic hyphema. So hyphema is called the blood in AC, anterior chamber, which is usually the innocuous and transient. IOP elevation may still result from trabecular obstruction by red blood cells. The size of the hyphema is a useful indicator of visual prognosis and risk of complication. A hyphema involving less than half of the anterior chamber is associated with 20% incidence of a complication and a final visual acuity better than 6/18 in 80% of the eyes. So basically the writer is trying to say that if the hyphema is small, then it is not much of a problem, and visual prognosis is just good in these cases. And if the if hyphema is less than one half of the eye, it can cause so there is a 20% chance of the complications, and final visual acuity will be better than greater than 6 by 18 in 80% of the eyes. However, if a hyphema involving more than half of the anterior chamber is associated with 80% incidence of complication, so you can say 20% was in the half and 80% in the uh, more than half, and a final visual acuity of better than 6 by 18 in only one third, and in only one third there will be the better visual acuity of greater than 6 by 18. The vision prognosis is determined mainly by the extent of injury to the retina sustained at the time of original injury. Severe and prolonged elevation of IOP may cause corneal blood staining and damage to the optic nerve. So, if the IOP has been prolonged for a long time, it can cause the cornea to be stained by blood and optic nerve damage. The optic nerve is endangered by IOP of greater than 50 millimeter mercury. So, if an IOP is elevated about more than 50 millimeter mercury of the hyphema, then it is more likely to damage the optic nerve. Secondary hemorrhage, often more severe than primary bleed, may develop within 3 to 5 days after the initial injury and is associated with reduced visual outcome. Patients with sickle cell hemoglobinopathies are at increased risk of complication, especially IOP elevation due to the trabecular meshwork obstruction by the deformed red cells and vascular occlusion. So, in the case of hyphema, one should always be very aware of the sickle cell hemoglobinopathy. Why? Because in such cases, you have to treat the patient early, especially if a patient is having a high IOP spike, because they tends to deteriorate more rapidly. So, how will you treat a patient with a hyphema? So, this is a hyphema. A is showing a small with the low risk of raised IOP, and B is showing secondary hemorrhage with the raised IOP and increased risk of glaucoma. So, how will you treat a case of a hyphema? Journal. A coagulation abnormality, particularly a hemoglobinopathy, should be excluded. Any current anticoagulant medication should be discontinued after the liaison with the general physician to assess the risk. NSAID should not be used for analgesia. Likewise, specialist advice should be sought regarding the management of a patient with a hemoglobinopathy, particularly before administering high-risk medication. Hospital admission may be required for large hyphema. Strict bed rest is probably unnecessary, but substantially limiting activity is prudent, and the patient should remain in a sitting or a semi-upright posture, including during sleep. A protective eye shield should be worn. So these are just the journal measurement. You ask the patient to rest and have with the pillow raised and in a 45-degree position, and a protective eye shield should be worn. So, what is the medical therapy if in a case of a hyphema? Topical prostaglandin beta blocker or topical or systemic carbonic anhydrase inhibitor is administered depending on the IOP. Carbonic anhydrase inhibitor should not be used in sickle hemoglobinopathy. Miotics should also be avoided as they increase the pupillary block and disrupt the blood aqueous barrier. Occasionally, a hyperosmotic agent is needed, though with the carbonic anhydrase inhibitor and alpha agonist, a high threshold is adopted in sickle patient. Topical steroids should be used since they reduce the risk of secondary hemorrhage and suppress inflammation. Atropine is often recommended in patients with hyphema to achieve the constant mydriasis and to reduce the chance of secondary hemorrhage. Antifibrinolysis with systemic aminocaproic acid ACA or tranexamic acid may be considered under the high risk circumstances such as recurrent bleeding. So basically you just treat the patient with first of all steroid. You give the steroid because there is a lot of inflammation going on with the RBCs and red blood cells, so you give the topical steroids. Then you give the patient mydriatics, especially atropine, so that there is no formation of posterior synecdoche and to achieve the constant mydriasis. Third, you give the IOP lowering drugs, which can be the prostaglandins, carbonic anhydrase inhibitor, and you can give beta blocker as well. But carbonic anhydrase inhibitor is contraindicated in a sickle cell hemoglobinopathies. You can give hyperosmotic agents like mannitol, but it is not necessary. But in the case of patient with the sickle cell hemoglobinopathies, you can give, because they are at more risk of having the optic nerve damage. So what is the laser photocoagulation? Laser photocoagulation of the angle bleeding points via gonios prism has been described. So gonioscopy should be probably be deferred for 5 to 6 days post injury. So this is one of the treatment that you just put the gonioscope and you ablate that portion of the vessels which is bleeding. Anterior chamber paracentesis or a surgical evacuation of the blood is required in around 5%. So very important, what are the indications of the surgery? The indications for surgery include a total hyphema, an IOP of greater than 50 millimeter mercury for 2 days, or IOP greater than 35 millimeter mercury for 5 days. Surgical intervention reduces the risk of permanent corneal staining and optic atrophy and prevent the occult development of peripheral anterior synecdoche and chronic secondary glaucoma. So indications of surgery is if the patient is suffering from the total hyphema, if the patient is having an IOP greater than 50 millimeter mercury for 2 days, if the patient is having an IOP of greater than 35 millimeter mercury for 5 days. So what is the reason of doing the paracentesis of the hyphema? Basically, you reduce the risk of optic atrophy and corneal staining. Particular vigilance is required in a patient with sickle cell anemia. Even moderate pressure elevation can lead to optic atrophy. Patient with prior glaucomatous optic neuropathy, and in young children with the risk of amblyopia, a glaucoma filtration procedure may be necessary in some patients. On discharge, the patient should be advised to avoid any activity with the risk of even minor trauma for several weeks. Symptoms of rebleed should prompt immediate review. Then is an angle recession glaucoma. Remember that hyphema is a type of glaucoma that occurs immediately after trauma. But angle recession occurs sometime because the angle has been damaged and it takes time to be manifested. Angle recession involves the rupture of the face of the ciliary body. So it is a rupture of the ciliary body, the portion between the iris root and scleral sclera, due to blunt trauma. Although a large percentage of eyes with traumatic hyphema exhibit some degree of angle recession, glaucoma only develop in less than 10% after 10 years. So it develops in less than 10% of the cases after 10 years. The rise in IOP is secondary to associated trabecular damage rather than from the angle recession itself. So very important, the pathogenesis, because there is a trabecular meshwork damage, not the angle has been recessed. Means the ciliary body has been ruptured. However, the risk of glaucoma is directly related to the extent of angle recession is unlikely to follow if less than 3 quadrants are recessed. So how many angles are being recessed depends on that, how much the glaucoma will occur. Presentation is with unilateral chronic glaucoma. Slit lamp examination may show signs of the previous blunt trauma. There may be mild or such as small sphincter rupture. Gonioscopy may initially reveal in irregular widening of the ciliary body face. So there will be the ciliary body widening. In long staining cases, the recession may be obscured by fibrosis and angle may show hyperpigmentation as well. Treatment: individual with more than 2 quadrants of angle recession should have their IOP checked on yearly basis. They should be reassured that their risk of developing secondary glaucoma is low. Medical treatment is as for other types of secondary open angle glaucoma but is frequently unsatisfactory. Laser trabeculoplasty is of no benefit. So in this case, medical treatment is not very effective because the pathogenesis is that the trabecular meshwork has been damaged. Trabeculectomy with adjunctive antimetabolite is generally effective, and artificial filtering shunt or cyclodiode should be considered if trabeculectomy fails. So that's it for the glaucoma part 10. See you in the next lecture.